Okay. Everyone see my screen? I'm going to take that as probably a yes. So welcome to Navigating Insurance and Disability Claims. During this webinar, all participants will have their mic and video muted. There will be a Q&A session at the end where the expert here you'll be able to submit your questions through the chat feature. We will also allow participants to come off mute and ask their question if they let one of us know in the chat prior. My name is Sydney Stern, and I am the Director of TGCT Support Programs, and I will be your moderator for today. We would like to thank Monica for spending her time and evening here today, and I will formally introduce her shortly, but thank you all for coming. I would now like to introduce our speaker. Monica is the co-founder and chief operating officer of Triage Health and Triage Cancer, a national nonprofit organization that produces educational materials on practical and legal issues that may impact individuals diagnosed with cancer and their caregivers, as well as other diseases like TGCT. And I will also let her take away and give a much more thoughtful introduction if she'd like to herself. You should be able to share, Monica.
Hi there, sorry about that. Just getting all my controls going. Thank you all so much for inviting me to spend some time with you this evening to talk a little bit about health insurance and disability insurance. As Sydney mentioned, I am the co-founder and chief operating officer for Triage Cancer, which is a national nonprofit organization that provides free education on all of the legal and practical issues that can arise after a serious medical diagnosis like cancer. So I am a cancer rights attorney, and I've been doing this work for many, many years now. And over the years, what we realized was that this information is really not unique to the cancer community, and that people with many different serious medical diagnoses could benefit from getting this information. But we would be asked to present at events like this one, and someone would say, and we'd send them back to our website to say, you know, here, you can go get more information. But then people would go to our website and everywhere it says cancer, and they'd say, but I don't have cancer. Does this apply to me? So to try to address that, we recently launched a new program called Triage Health. So while the organization is still a cancer organization, through Triage Health, we are trying to provide the same award-winning education to anyone who needs it. We are going to spend about an hour together today, but believe it or not, we're really just going to scratch the surface of this information. And so throughout the presentation, I'm going to be pointing you back to the websites, both triagehealth.org and triagecancer.org, where you'll find a number of different resources and materials that will supplement the information I'm going to give you today, but that also might be on other topics you are interested in learning about, like planning ahead, for example. Some of the resources you might find are things like our quick guides and checklists and worksheets, which are shorter snapshots of a particular topic, or animated videos. We have recorded webinars. So just know that after today, this is not the only opportunity for you to get this information. Also, please do forgive me as I switch back and forth between Triage Health and Triage Cancer. Sometimes it's just force of habit while I'm speaking. But with that under our belts, we're here to talk about health insurance. And one of the reasons we spend so much time talking about health insurance is that it is confusing. So if you feel like you don't have the best grasp on how health insurance in this country works, please know that you're not alone. In fact, when surveyed, 96% of Americans could not define the four most basic words that are used in health insurance. So here we are in a system where if people don't even understand the words, how can they possibly be effective at purchasing insurance or choosing insurance? And the answer is they can't. We often say that there should be a class in high school on health insurance and finances, because we all need to navigate this at some point, but rarely is anyone ever taught how to do this. So I'm going to start today with some level setting. I recognize that some of you might be quite familiar with these words, so bear with me if you are, but I want to make sure that we're all on the same page. There are three main places we get health insurance in this country. So about 50% of Americans get their insurance through an employer. Then the second place to get health insurance is through the government, primarily through Medicare, Medicaid, or military plans. And then someone might go directly to a health insurance company to purchase health insurance. But regardless of where someone gets their health insurance in our triangle of coverage, there are words or terms that you need to understand. And these are terms specifically related to the cost of having health insurance. So just to have health insurance, someone has to pay their monthly premium. And this is a fixed dollar amount that is going to depend on the policy. And it's what we have to pay each month just to have the health insurance. So we're going to pay this monthly premium whether we go to the doctor or not. It's similar in concept to having car insurance all year, but never getting into an accident and filing a claim. But then there are some additional costs that we have to pay when we try to use our health insurance. And the first is our annual deductible. This is a fixed dollar amount that we have to pay each year before our health insurance kicks in. Again, this is going to depend on the policy. So someone could have a $500 deductible, someone else could have a $5,000 deductible. All depends on the policy. But once someone pays that deductible, then their insurance kicks in and pays a percentage of the healthcare costs. And that percentage is referred to as cost share or co-insurance. And one of the reasons this gets so complicated is sometimes we have two words for exactly the same thing. So here we are. So for example, if someone has an 80-20 cost share, then once they've met their deductible, insurance is going to pay 80% of their healthcare costs and the individual is responsible for 20%. But many policies have an additional payment called a copayment. And this again is a fixed dollar amount that's going to depend on the policy. It could also depend on the service. So someone could have a policy that has a $20 copayment when you go to the doctor, or a $35 copayment to see a specialist, or a $250 copayment if you end up in the emergency room. And many policies will impose both a co-insurance, where you're paying a percentage, plus a copayment to the same service. One of the most valuable things for us all to understand about our health insurance policy is the out-of-pocket maximum, because the out-of-pocket maximum is a fixed dollar amount that represents the most we are going to pay for our health care in a year. And once you meet that out-of-pocket maximum, insurance will cover your health care at 100% for the rest of the year. The way that you would get to your out-of-pocket maximum is a math problem. So for example, you could have a policy that has an out-of-pocket maximum that adds up everything you've paid towards your deductible, everything you pay towards your co-insurance, and everything you pay towards your co-payments. So it's everything you're paying out of pocket except that monthly premium. When we talk about this, it can get a little bit confusing. So I want to give you an example. Meet Dan. Dan has a plan with a $2,000 deductible. It's an 80-20 co-insurance, and he has an $8,000 out-of-pocket maximum. Dan hasn't gone to the doctor at all this year, but he gets into an accident, and he spends a week in the hospital and ends up with a $102,000 hospital bill. So what does Dan have to pay? The first thing we always pay is that annual deductible. So he pays that $2,000 and it leaves $100,000 of the bill left. Now his co-insurance kicks in because he's met his deductible at 80%, and Dan's responsible for 20%. 20% of $100,000 is $20,000. But because Dan has a plan with an $8,000 out-of-pocket maximum, he doesn't have to pay that full $20,000. Rather, he has to pay another $6,000, and that's because he's already paid $2,000 in his deductible. Once he pays $6,000 of his co-insurance, he's reached that $8,000 mark, and he won't have to pay the remainder of the bill. Now, I'm not suggesting that $8,000 isn't a lot of money. Of course it is. But when we start to look at the alternatives of what he would have to pay without the out-of-pocket maximum, which would have been $22,000, or certainly what he would have had to pay without having health insurance, which would have been $102,000, $8,000 starts to feel a little bit more reasonable. The other thing about understanding the out-of-pocket maximum is it allows us as consumers of health insurance and health care to plan around a worst-case scenario. It also is critical in understanding how to pick a plan, which we're going to get to in just a minute. But I do just want to say that if you would like to hear any of that again, or you have friends and family that might benefit from hearing that information around the terms and this example, you can find that in our animated video on health insurance basics. It's about a 6-minute long animated video, and it walks through this example. I do just want to mention when we talk about out-of-pocket maximums that the devil's really in the details. So someone could have a plan that has an individual out-of-pocket maximum, but also has a family out-of-pocket maximum. So that's a situation where if someone has multiple family members on the same plan, they could have 2 out-of-pocket maximums. And then that math problem I mentioned could depend on where someone is getting their insurance. So for example, if someone's getting their insurance through their state health insurance marketplace, it's required that that math problem is as I've explained it. Everything you pay towards your deductible, everything you're paying towards co-payments and co-insurance. But when we start looking at employer plans, employers are allowed to come up with their own math problem. So sometimes employers might say, okay, here's your out-of-pocket maximum, but we're only going to look at payments you're making towards co-payments and co-insurance. It doesn't include your deductible. Or sometimes they're going to say, well, it doesn't include your deductible or your co-payments. It's just going to include co-insurance. So again, it's important not just to know what the dollar figure is for your plan, but also if you have an employer plan, what is that math problem that they are looking at? I will also say that typically when we are talking about out-of-pocket maximums, their policies are usually only going to count payments made towards in-network providers. So if you go out of network, it could be a different situation. So when we think about health insurance in this country, there are 2 main payment models. One payment model is called fee for service, and that's a situation where someone can go to any provider and there's going to be a specific amount that their plan is going to cover. The more common type of insurance that many people have through an employer or through the marketplace is going to be something called managed care. And managed care is where you have a network of providers that you stay within. And if you stay within, then insurance is going to cover it at a higher rate. But where it gets particularly confusing is that within the concept of managed care, there are lots of different options. And here are some of the more common types of managed care plans. On one end of the spectrum, we have something called a health maintenance organization, or an HMO. HMOs are generally going to have smaller networks of providers. And with HMOs, typically someone has to start all of their care with a primary care physician. And then if the primary care physician can't solve the problem, then there's a referral out to a specialist. So with HMOs, there's less choice of providers, and there are sort of more hoops to jump through because you always have to start with that primary care physician. In exchange, you're going to pay less for these plans. On the other end of the spectrum, we have preferred provider organizations, or PPOs. These are going to have the largest networks of providers, sometimes across different hospital systems, sometimes even across state lines. Many PPOs also provide coverage for out-of-network providers, so they won't cover it at as high of a rate as if you went to an in-network, but they'll cover it at something. And with PPOs, you don't have to start with a primary care physician, so you can go straight to that specialist if you wanted to. So in exchange for all of this choice and flexibility and additional coverage, you're going to pay the most with PPOs. And then there's sort of multiple things in the middle. One example is an exclusive provider organization, or an EPO. These are going to have a larger network of providers compared with an HMO. So there's going to be more choice than with an HMO, but no out-of-network coverage. So if you go out of network, that plan pays 0. So you have a little bit more choice with EPOs than you do with an HMO, you're going to pay more. Cost is going to be in between an HMO and a PPO. So sometimes people will say to me, well, which is better? And the answer is it depends, because it's going to depend on what's available to that person where they live. There are some places in the country where the HMOs are perfectly adequate. There are some places where the exact opposite is true, but also about their needs. So if I talk to, a super healthy 30-something who never goes to the doctor, has no medical issues, and, just an annual checkup kind of thing, then maybe an HMO makes perfect sense for them. If I'm talking to someone in the cancer community or with a serious or chronic illness that might have specialists across the hospital systems, then probably a PPO is going to be the best choice. So this is just one of the many examples we have in the work that we do where there isn't a one-size-fits-all answer. One of the reasons it's so incredibly important to make sure that we understand these terms, including the out-of-pocket maximums and whether it's an HMO or a PPO or some other types of plans, is all of that information is imperative for us to be able to compare our plan options. I'm going to walk through an example using a state health insurance marketplace, but the same exact analysis works whether you're trying to compare two marketplace plans, two plans offered by an employer. Maybe you're in a situation where you're like, do I take my employer plan or do I take a marketplace plan? Or even if you're trying to compare two Medicare Advantage plans, the same exact analysis works. And one of the reasons that this concept that I'm about to walk through is so foreign to many people we work with is the ability to purchase health insurance regardless of having a pre-existing condition. That right is only about 10 years old since the Affordable Care Act went into full effect. And so the good news is we have more options than we've ever had in the past. The bad news is we have to make decisions between those options, and we might not know how to do that. So here are three different plan options. There is a bronze plan that has a $200 a month premium, a $600 deductible, and an $8,000 out-of-pocket maximum. We have a silver with a $275 a month premium and a $6,000 out-of-pocket maximum, and a platinum plan at a whopping $400 a month with a $2,000 out-of-pocket maximum. Can we tell just by looking at this screen which plan is going to cost us the least, assuming we're going to hit that out-of-pocket maximum, which is a relatively safe assumption for someone who is dealing with a serious or chronic condition? The answer is no. We actually have to do a little bit of work, and that work includes doing the math. And the way we do the math is we take the monthly premium and we multiply it by 12, because that's how much we're going to pay in premiums for the year. And then we're going to add the out-of-pocket maximum. When we do that math for all three plans, we see that that platinum plan at $400 a month actually ends up being significantly less expensive at the end of the year. And typically, platinum plans also have a larger network of providers. One of the challenges is that because people aren't taught how to do this, they only look at that monthly premium and they think, well, why would I pay $400 a month when I could pay $200 a month? Or, oh my goodness, I can't afford $400 a month. Instead, I'm going to pay the $200 a month. But what they don't realize is that without doing this math, they might end up spending thousands of extra dollars, and they might end up with a plan that has less choice with respect to providers. But I will say that doing that math and finding out that total end of year dollar figure is only a piece of the puzzle. There are sometimes other things that people need to take into consideration, like deductible, for example. This math is going to end up differently each time you do it. So it's not always going to be the platinum plan that ends up the cheapest, but sometimes two plans are really close in terms of dollar figure at the end of the year. And then we'd say, okay, well, then you have to look at the deductible. Here in this example, that platinum plan has a $0 deductible, which means that it starts picking up 90% of your healthcare costs on day one. Whereas the bronze plan has a $6,000 deductible, which means if you go in for an expensive procedure at the beginning of the year, you are writing a $6,000 check before insurance picks up anything. So again, yes, the total annual cost is important, but we also want to take into consideration those other costs as well. And then before someone picks that plan for the year, they want to double check that any providers or facilities that they are currently using or that they might want to use in the year ahead is included in that network of providers. And the same for prescription drug coverage. So every plan has a list of covered drugs called a formulary. And so people should be looking at any current drugs they're taking to make sure they're on the formulary. I also will sometimes say to people, have a conversation with your providers and say, well, are there any other drugs I might potentially need to start taking next year? Because then you can do a little bit of pre-work to see if those potential medications might be listed on the formulary. The good news is that we have the ability to make choices about our health insurance every single year. And that is true regardless of where we get our health insurance. So every single year, we can make new choices. It's good news and bad news because it means we have to do it every single year. But when someone comes to me and says, I can't see the providers I want to see, maybe I've now have this new diagnosis and the specialists that I want to see are not in my plan's network. There's two sort of pieces. One piece is around, okay, well, how do we get you coverage for that now? But then the other piece is, can you make different health insurance decisions for the year coming so that those providers are in your new plan's network? So we do get to make choices every single year and make changes, and that's great news. But we also, once we get that plan, have to make sure that we are using that policy to its full effect. And there's a couple of things that means. The first is that we're using in-network providers whenever possible, and that we're asking for prior authorizations before big things. So there's lots of challenges with prior authorizations. One of the challenges is there typically isn't a comprehensive list that we're given where it says, if you're getting any of these services, you need a prior authorization. But generally, you're thinking things like surgery, MRIs, CAT scans, expensive medications. Those will typically require a prior authorization. There's also some strategies around leveraging those out-of-pocket maximums. So for example, if you've already hit your out-of-pocket maximum for the year, thinking about, is there any other medical care that you need? Can you get it this year? Is it medically appropriate for you to get it in this calendar year? And so I'm not suggesting that people get care they don't need, but oftentimes when we are dealing with something serious, other things can get put off. Or sometimes there's sort of a long-term thing. I always think about, I played water polo and I have this trick shoulder. If I hit my out-of-pocket maximum, that's the year that I should go get the MRI because that MRI will be free essentially. But if I wait until next year, then I'm having to meet my deductible and I'll have to pay a co-payment for it as well. The same is true around family out-of-pocket maximums. So if two members of the family have had medical situations that have made it so that the family has met their out-of-pocket maximum, thinking about, are there other family members that need medical care because they would get it covered for free. And then finally, it is an unfortunate reality of our healthcare system that you might experience denials of coverage from your health insurance. Denials are incredibly common. The takeaway is that you shouldn't take no for an answer. In every type of health insurance, comprehensive health insurance, there is an opportunity to appeal. I know that many of you might have different types of coverage, but for those that have either an individual policy or a policy through work, there are at a minimum 2 levels of appeal. And the first level is an internal appeal. And this is where you're going to go back to your insurance company and ask them to reconsider. You're going to want to gather evidence that shows why the service that you requested is medically necessary. That's the legal standard. But even if you get denied at the internal appeal stage and insurance comes back and still says no, then you have the right to what's called an external appeal. And that's where you go to an independent entity, and that an independent entity is going to look at the policy and the medical information, and they're going to decide whether or not the service is medically necessary. This is one of those things where it's sort of inherently unfair because we're just adding to the plate of people who are dealing with serious or chronic medical conditions. And now we're saying, okay, go fight your insurance company. But I will tell you that we have data that shows that people who go to the external appeals stage, between 40 and 60% of all of those appeals are decided in favor of the patient. So conservatively, that means about half the time when the insurance company is saying, no, we're not going to cover that, they're getting it wrong. That's really significant. And if people aren't availing themselves of the appeals process, it means either they're not getting the care they need, or they're paying for it out of pocket, which obviously is a huge financial burden. So this appeals process is a really, really important tool. But the reality is there's a number of hurdles, including lack of knowledge around the appeals process. So this is data from 2021, just of the state health insurance marketplaces. So that's a small segment of people. Of the 48 million denied claims, 99.9% of them were never appealed, even to the first level. Yeah, I just told you when people go to the external appeal, about 50% of them win. And so the knowledge factor around appeals is a significant hurdle. We have a ton of resources on both websites around appealing that I welcome you to take a look at if you're experiencing denials. I will also just say that someone can appeal a decision pre-service. So maybe that's a situation where you've asked for a prior authorization and it's been denied. You can appeal at that stage. You can also appeal if you've gone and gotten the service and then been denied. There is also an opportunity when the need for the service is urgent. Then you and your healthcare provider can make a claim for that and ask for what's called an expedited appeal, which means that the insurance company and the external appeal entity has to give you an answer within 72 hours. So we often will hear from healthcare providers, I don't do the appeal because my patients can't afford to wait because they don't know that they have the ability to ask for the expedited appeal. I will also say about appeals that this is a strategy that can be used if someone is trying to get a second opinion, and perhaps the only person that can provide the second opinion is out of network. In those situations, someone could do an appeal, and the type of appeal is a network gap exception appeal. And so basically you're saying the network of providers isn't adequate for me to get a second opinion because there isn't a doctor that can give this second opinion in our network. So we're asking you to make an exception for the network for me to go out of network. So this appeals process is just incredibly valuable for a number of reasons in order to access care. Okay, I'm going to switch gears into the employment piece and disability insurance, but I certainly welcome questions in the chat box around health insurance and appeals, and I'm also going to point you to some other places where you can get some more information on that as well. So when we are looking for our employment rights, there are a couple of different places we can go. So there are fair employment laws at both the federal and state levels that are going to provide protection against discrimination and provide an additional tool called a reasonable accommodation. There are also leave laws at the federal, state, county, and sometimes city level that are going to provide for some job protected leave around medical care. And then if someone is working under an employment contract or is a member of a union, that employment contract or collective bargaining agreement could provide some additional or different rights and benefits. But we often forget that the law is just the bare minimum of what employers have to provide. And many employers are, in fact, more generous than that bare minimum. So we should also be looking not just at the law, but also what are your specific employer's policies around providing benefits like health insurance or disability insurance, sick time, vacation time, PTO. Though that's a really great place to start for a lot of these questions. Many times employers will have a formalized handbook. If they don't have some sort of handbook or portal or written down somewhere, then we sort of say, well, who's the person at your job that handles HR-like tasks? At the bare minimum, I will say, if you really have no clue, go to who you turn your timesheet into as a starting point, and then start asking questions. There are a couple of laws I want to talk about relatively briefly because they're really valuable for anyone who's dealing with a serious or chronic medical condition who's trying to work through treatment or take time off. And the first is the Americans with Disabilities Act, or the ADA. The ADA does lots of things in many different contexts, but in the employment context, we're talking about Title I. In order to use the ADA, there are a few eligibility requirements, including working for a private employer with 15 or more employees, or a state or local government. If someone is a federal employee, they have similar rights, but it is under a different law. Someone also has to be qualified for the job in question and have a disability under the ADA's definition. The word disability gets thrown around a lot, and it is important to remember that under each law or program, there could be a different definition of disability. So under the ADA, a disability is a physical or mental impairment that substantially limits one or more major life activity. And I know it's a mouthful, so when you break it down, you have a physical or mental condition that is impacting a major life activity. So what's a major life activity? Well, it's anything that's major. Walking, talking, speaking, breathing, sleeping, operation of major bodily functions. Those are all major life activities. Sometimes when people are thinking about if they meet this definition, they only think about the diagnosis, the tumor, the cancer itself. When in reality, in many of these situations, it's the side effects either of the tumor itself or of the treatment that can give rise to the disability. So if someone is in extreme pain all day long that makes walking incredibly challenging, that could give rise to the disability. What does the ADA actually give someone? Well, there's 4 ways to use it. So the first is that someone currently has the disability. So they're currently in treatment and dealing with severe nausea. They have a history of having a disability. So maybe they are dealing with late or long-term side effects. The third is being regarded as having a disability. So this isn't really about the employee at all, but rather it's about the employer's perception of the employee. Or it could be based on someone's association with a disability. And that's where caregivers can get some protection. And in all of these circumstances, eligible individuals are protected from discrimination, which means the employer can't make employment-related decisions based on medical information. But for someone who currently has a disability or who has a history of having a disability, in addition to being protected from discrimination, they're entitled to a tool called a reasonable accommodation. Now, I've given you the definition of reasonable accommodations here on the slide, but frankly, I don't think it clarifies a whole lot. The easiest way to talk about reasonable accommodations is through some examples, and they fall into 3 main categories. The first is about adjusting workspace. So maybe this is about moving offices. So someone's parking space is closer to their office, or special equipment, It could be about telecommuting if that's appropriate based on somebody's job, which might mean working from home, or it might mean working from another location. We have lots of people we've spoken to who have computer-based jobs and have been able to work from infusion suites, for example. So that's about your physical space. Where and how are you working? The second category is around schedule. And so this could mean changing shifts or a flexible schedule, additional breaks. It could also mean extended leave. And then there's a whole bunch of other things like using technology or changing responsibilities or shifting job responsibilities or changing jobs entirely. So reasonable accommodations are an incredibly valuable tool because they're so flexible and people can get more than one. They can change as needs change. And they're a really incredibly useful tool for people who are trying to work through their diagnosis or their treatment, or who are trying to potentially take some time off. For someone who works for a smaller employer that doesn't have to abide by the ADA, then we're going to probably want to look to see if there is a state fair employment law. Almost every state has a state fair employment law, and you can see the details of these laws on our charts of state laws. One of the reasons the state fair employment laws are more protective is that they can sometimes cover smaller employers. So for example, if someone lives in Illinois and they work for an employer with 1 to 14 employees, they're not going to be eligible for the ADA, but they will be eligible for the state fair employment law. If you don't see your state listed here, then it means it's the same as the federal requirement at 15 employees. So this is our first example where we can't just look at the federal law. We also have to look at what's available at our state level as well. For people who need to take time off, they might be eligible for the Family and Medical Leave Act, or the FMLA. And this is a federal law for the employee with their own serious medical condition to take job protected leave, or for an employee who has a seriously ill child, parent, or spouse. This is a very narrow definition of family. I recognize that, but that is the definition under the FMLA. So someone cannot take FMLA to care for a sibling or a mother-in-law or an aunt or a grandparent. It is only child, parent, or spouse. There are some eligibility requirements to use the FMLA as well. You have to work for an employer with 50 or more employees or be a government employee. And you have to have worked for that employer long enough, which means you've worked at least 12 months cumulatively over the last 7 years. And in the last 12 months, you've worked at least 1,250 hours, which comes out to be a little bit more than part-time. If someone is eligible for the FMLA, it provides up to 12 weeks of job protected leave per year. The FMLA is unpaid. And so sometimes people are like, why do I want FMLA? And the real reason is that it is job protected leave. Oftentimes people don't realize that even if they have sick time saved up or vacation time saved up, that's not job protected leave. And if you are taking sick time or vacation time, you can be let go. That's not job protected leave. Sick time and vacation time is really just about the money replacing income. It's the FMLA that provides the job protection. So we often say someone is in an FMLA bubble because they are like bubble wrapped and protected to save their job. But it is unpaid leave. And so what does someone do to replace that lost income? Most of us can't go 12 weeks without any sort of income. And that's where disability insurance benefits come into play. Disability insurance is insurance that will pay a percentage of what someone was earning at work. And this money can be used for anything. So it doesn't necessarily have to be about healthcare costs. And that's where it's really different from health insurance. There are a couple of different places someone might be able to access disability insurance. So there are private insurance policies that someone might get from a company directly. So sometimes that's a employee benefit you might get, or sometimes that's something someone's actually proactively gone out and purchased. With private disability, there are short-term policies and long-term policies. The details of private disability insurance are going to vary greatly from policy to policy. So typically when someone asks us a question about their private disability insurance, the response is, you've got to go back and look at the policy because we just can't know since they're all so different. There are a handful of states that have state disability insurance programs. As you can see, there's just not a lot of them. The details do vary from state to state, but if you live in one of these states and want more information, we do have a quick guide to state disability insurance on both websites, actually. And then there are 2 federal disability insurance programs. Both of these programs are run by the Social Security Administration, and both are long-term disability insurance programs. The first is Social Security Disability Insurance, or SSDI, and the second is Supplemental Security Income. There are some similarities between these programs and some differences. The similarities are around the definition of disability. So the Social Security Administration will define someone as having a disability if they cannot do their job and they cannot adjust to a new job, and their disability either has or is expected to last for a year or longer or result in death. So this is the highest standard of disability that we have across all the different programs, because it isn't just about, can you do your job? It's about, can you adjust to any other job? But I will also say to you that when thinking about if someone meets this definition, it's the same as around reasonable accommodations. It might not be the tumor itself, but rather it might be the side effects of treatment or the side effects of having the tumor. In terms of the differences, SSI, Supplemental Security Income, is a program for individuals who meet that definition of disability and have a low income and asset level. With SSI, there is a monthly maximum that the federal government will provide, and right now that's $943. If someone is eligible for SSI, then their benefits do start right away, and typically someone would also be eligible for Medicaid as their health insurance. SSDI, on the other hand, is based on work history and having paid into the system over that work history. The amount that someone is going to get monthly from SSDI is going to depend on how much they've earned over their working history. So Bill Gates is going to get more from SSDI than I would as a nonprofit lawyer. With SSDI, there is a 5-month waiting period from the date the disability began. There are really no ways to get rid of that 5-month waiting period in the context of cancer. And sometimes people will hear things like the compassionate allowances list. There are a number of programs like the compassionate allowances list that speed up the application process. They do not eliminate the 5-month waiting period. If someone has been receiving SSDI for 24 months or longer, then they become eligible for Medicare. And that's the only way to become eligible for Medicare under the age of 65, outside of having end-stage renal disease or ALS. So I know that that was like a really quick overview, but know that we have a ton of resources, and I'm happy to answer questions about these programs. But one of the things that we get asked about all the time is, what happens if I get denied? The first thing I will say is, know that you're in good company. About 65% of all applications are denied on the first try. The good news here again is that we don't have to take no for an answer. There is a robust appeals process. And this is where you really do want to enlist the help of your healthcare team to help you document the medical condition, but not just the medical condition, because really the Social Security Administration doesn't care about that. What the Social Security Administration cares about is, how is that health condition impacting your ability to work? So this is where you want to throw in everything, all the things. So for example, if someone is going through treatment and they're experiencing a huge amount of pain, which means then they have to take pain medication, which also makes them incredibly fatigued. The pain the fatigue gets added into the application. Sometimes someone might also experience some mental health challenges around this diagnosis, like anxiety or depression. Those should also be included. So this is where we want to talk about all of the things that the human is experiencing and how those things are impacting their ability to work. The first level of appeal is a request for reconsideration. And sometimes people will ask, well, do I need a lawyer to do this? And I would say for the initial application and for the first level of appeal, the lawyer is not your best professional ally. The best professional ally in these two stages is your healthcare team, because they're really going to be able to help you document the medical evidence behind what you are experiencing. However, if you do end up continuing to have to appeal to higher levels, like that hearing by an administrative law judge, then you might want to consider hiring a disability attorney. And the reason for this is it's a very specialized practice of law and a very unique court proceeding. It's not like anything you're going to see on like a TV courtroom drama. And to be perfectly honest, if I were ever in this position, even though I do this kind of work day in and day out, I would hire a disability attorney just because of that expertise. People will sometimes ask me, well, wait a minute, I'm not working, so I don't have any money. How am I supposed to hire an attorney? These types of attorneys work on contingency, which means that they don't get paid unless you win. And what they get paid is actually capped. So they're entitled to 25% of any back pay that you're owed, up to a certain amount typically. So that amount is going up to $9,200 this year. But when you think about it, it's only about back pay. It's not about any money you're getting moving forward. And I always look at it like, yes, you have to pay the attorney a big chunk of money, but without the attorney, you might not get that money anyways. So for more information on hiring a disability attorney, we do have a quick guide to finding legal assistance available on both websites. We also have on our websites resource hubs. And so we have hubs on employment and health insurance and disability insurance, where if you want to just go learn more about a particular topic, you can always start at that hub. And then on that website page, you'll see all the resources that we have related to that topic. So our quick guides, our charts, any recorded webinars, any animated videos are all going to be available for you on those pages. I know that this is a lot of moving pieces, but I do just want to kind of put some of the pieces together, particularly for individuals who might be in a position where they're trying to take time off for treatment and they're trying to figure out what their options are. So Jane's doctor has suggested that she consider, quote, going out on disability, but she also has 3 weeks of vacation time, 3 weeks of sick time. Her employer is covered by the FMLA, and she has a short-term disability insurance policy that lasts up to 12 months. So what are Jane's options? Starting on the job and health insurance side, she could take 12 weeks of FMLA because that's going to protect her job. She can't be let go during those 12 weeks. But it's unpaid. So what is she going to do to pay her bills? Well, at the same time as taking her FMLA, she can take her 3 weeks of sick time, her 3 weeks of vacation time, and kick in or tap into her short-term disability insurance for the remaining 6 weeks. So this sort of shows you how you can use each one of these pieces by themselves. But when you start to use all the pieces together, that's where you're going to get the greatest amount of protection and benefits. Sometimes, though, someone might need more than 12 weeks. And so here's Mark, who has the same benefits, but he needs to be out for 15 weeks. What's he going to do? So starting on the money side this time, again, he can take his 3 weeks of vacation, his 3 weeks of sick time to pay him. Then he can tap into that short-term disability insurance policy for the remainder of the time. But none of the things that are currently on the screen protect his job. So he can take his 12 weeks of FMLA, but what does he do for the last 3 weeks? Here's a situation where we can use the two employment laws together, because after his 12 weeks of FMLA, he can go back to his employer and actually request the additional time off as a reasonable accommodation under the ADA. So again, each piece can be used by itself, but when we start to use them all together, we're getting the greatest amount of protection. So I want to leave time for questions, but I also know that I may have just opened up a whole can of worms. So as a reminder, we do have upcoming live educational events that you are welcome to come to. You do not have to have a cancer diagnosis to attend our events or look at our websites. And our upcoming events are around work issues, Medicare, prescription drugs. We also record all of our webinars. And so if you've missed one or you can't attend live, you are welcome to watch the recordings. They're all available on our website. We also have a bigger event that's open again to anyone. This is not specific to individuals who have been diagnosed with cancer. The event is a 2-day conference. It's all virtual. It is totally free to attend. Everything that Triage Cancer provides is free. All that we ask is that you register on our website. And then finally, we recognize that we can provide all of the events and all of the materials in the world. People are still going to have questions about their specific situation. So in those circumstances, we do have a legal and financial navigation program where you can fill out a form on our website. Again, you do not have to have a cancer diagnosis. You can indicate another medical condition if you'd like, and then tell us a little bit about your question. You'll then get a link in your email to schedule a phone call with us. We get on the phone and we try to answer your questions and explain your options or give you your next steps. This is totally free and available to anyone. So with that, I am happy to take some questions.
Thank you so much. You are incredible. And I don't know where you were when I started my journey, but it learned a lot. And we have several questions, so I want to get going. And I did want to ask you if you had 5 minutes to stay past your time.
Yes, not a problem.
Wonderful. So someone had asked, what's the difference between coinsurance and copay, or are they basically the same thing?
They are not the same thing. They are very, very different. Coinsurance is a percentage that you are going to pay for each service. So for example, you might have a 90-10 plan. That means once you've met your deductible, insurance picks up 90% and you're responsible for 10%. It's always going to be a percentage. Co-payments are a dollar figure. So it's going to depend not only on the policy, but also on the service. So for example, you could have a co-payment of $20 to see your primary care physician or $30 to see a specialist. You could be in a situation where for one service, one doctor's visit, you're going to have both your co-payment, which is your $20 to get in the door, and your co-insurance, which is going to be a percentage.
Insurance is expensive. So someone within the chat also mentioned that they're dealing with the same thing where their plan won't cover an additional person to be reached out to. And so they're wondering if they could apply for a state plan despite having access to an employee plan, but the plan is restrictive and not going to cover what they need.
So we are not required to take our employer insurance. We can say no thank you and go purchase in the marketplace. The one thing to keep in mind though is that if you do that, if you are offered comprehensive health insurance through an employer, you won't be eligible for financial assistance to purchase a plan in the marketplace. So you can definitely buy it, you'll just have to pay full price for it. But for many people, that makes so much more sense because paying full price for a policy that covers the providers they need to see is going to be less expensive than having an employer policy that doesn't cover their needs.
And that wouldn't be COBRA, right? There's other options.
It would be through the state health insurance marketplaces, which is what the Affordable Care Act or Obamacare created. So you're actually purchasing policies from private insurance companies, Blue Cross Blue Shield, Aetna, Humana, like there's hundreds of them. So you're buying private insurance, but you're doing it through the marketplace, which we often call like a shopping mall for health insurance or Amazon for health insurance. You're buying private insurance, but it's through the marketplace, which adds some additional protections.
And then Jessica had another specific question. I wanted to let her come off mute. So Jessica, you should get a request to come off mute. Go ahead and ask.
So my question is, if you, okay, so I have 10 synovial giant cell tumors, and I've been to 3 different doctors for the treatment, and it's in my foot. So I was wanting to know about Social Security disability insurance, and how, like, I don't really have a care team, if that makes sense, because nobody's really, they just, like, I had surgery with a podiatrist, and then I had surgery with an oncologist, and then that oncologist retired, and I just seen a new oncologist today.
So how would you
And I'm
start
probably
the
gonna do
process
another
then,
one.
right? Is what you're asking for Social Security disability?
Yeah, so like with me seeing multiple doctors, like what do I need to do um to get them to advocate for me, if that makes sense? Like, it's in my
Yeah.
foot. I'm a nurse. So like right now I'm not working. Surgery's not an option, so they're talking medications. Um, I'm very sensitive to meds. So like I'm concerned, if that makes sense.
It makes perfect sense. I think, obviously it's complicated by having to start over with a new oncologist, but I think that is step one. What I would probably do beforehand is some pre-work. So literally writing out, like, how is what you are going through impacting your ability to work, and really connecting the dots. Like, I can probably make it from it's in my foot to I'm a nurse, but literally, like, for the provider, talking through, I can only, and I'm making this up as an example, like, I can only stand comfortably for X amount of time. I have to walk I can only walk Y amount of distances. My job would require A, B, and C, and that's why this doesn't work. And then literally sitting down with the oncologist and potentially a social worker, if they have one on staff, to flush out connecting the medical condition to the inability to work, and then asking for their help with the Social Security disability insurance application. But what you're going to have to show is that you can't adjust to a new job. And that's sometimes the tricky part. So, for example, like, could you do nursing where you are sitting, answering questions on the phone, like telehealth type stuff? So thinking through the possible rebuttals the Social Security Administration might have about being able to adjust to a new job, and then being able to have counter arguments with that.
That's where something like depression or side effects to drugs could come in, right? Like if you're so nauseous, you can't sit at a desk. You can tell I've clearly talked about it before, and I think your internet
Sorry, I keep losing you guys, so I'm going to go off camera because I think the Wi-Fi is acting up.
You're good. Did you hear?
I heard, like, is that where, like, depression or anxiety or
Using other
sensitivity to
aspects of
medication?
the disease,
Yes,
right? Or side effects to the
absolutely.
drug. I know Jessica had mentioned maybe she's going on a drug, and drugs may have side effects, and those can be used as well.
Absolutely, because it really is, in law, we call it a totality of circumstances. So it's looking at the biggest picture and how are all the different pieces that you're experiencing impacting your ability to work.
So someone also had a question about network appeals. Using Kaiser as an example, within that system, say that there isn't another option for a provider, but maybe a provider there thinks that they can provide a second opinion. Is there a way to get a second opinion from someone that's a known expert, we'll say? So maybe someone within network thinks that they can give that second opinion, but it may not be actually a valid second opinion for our rare situation of disease.
Yeah, it is tricky. I'm not going to sugarcoat that at all, but that is where using the appeals process for what's called an exception gap request. So showing, why is it medically necessary for you to get the second opinion from this other specialist? Sometimes you're going to be successful, sometimes you aren't. I am putting a link. I don't know if we can share this with the attendees, but there is a link that we have to our checklist to getting a second opinion that has some more details and some practical steps included in it.
And for those listening to the recording, we will put this in the link in the caption below.
Awesome.
We also wanted to ask about off-label drug appeals. So off-label drugs are inherently not approved for the use that they're being used for. So is that appeal process similar to any of the other appeals?
Yes, it is almost exactly the same. What you are asking for is an off-label exception where you're going to have to show that using that drug off-label is medically necessary.
That's very helpful. I think you answered kind of, but when should you get a lawyer involved? You said maybe on the second appeal. Should that always be the case, or is there exceptions to different areas in which you would get someone involved earlier?
I mean, there's always going to be exceptions to the rule, specifically when we're talking about disability insurance. It is generally not necessary to get a lawyer involved until you get to the appeals with the ALJ stage. Because as I was saying, you know, the professional that is going to be most useful in your first level of appeal is really a healthcare provider, because they're going to be better adept at showing why your specific medical situation gives rise to the disability. So that's going to include things like test results, medical records, a letter perhaps from that provider, you know, a personal narrative from you. So, you know, a lawyer isn't necessarily going to be the one that can get those access to those medical records. Rather, a healthcare provider can.
And then another patient had asked, so they have hit their out-of-pocket max, but they keep receiving a bill, we'll say for 50% of a medical procedure. What should be their first step?
First step would be to make sure that that provider was in network, because if someone is telling me 50%, that sounds like perhaps it was an out-of-network provider, and their plan only covers 50% for out-of-network providers. And as I shared, most of the time when there's someone has an out-of-pocket maximum, it's only going to take into consideration payments made for in-network providers. So that would be step one. If someone does figure out, no, this is an in-network provider and I continue to get this bill, I think contacting the billing department is a great next step to figure out why someone's getting billed for that. If someone's in a situation where they did their due diligence, and let's put it this way, a common scenario is someone goes to, someone has surgery and they did their due diligence, the hospital was in network, the surgeon was in network, they go and have surgery, and then they find out after the fact that the anesthesiologist was out of network. Right? Like that's a common scenario.
Yeah. Or facilities fee, right?
Right. So that could be considered a surprise bill. Like, how would you have known that that anesthesiologist was out of network? Now, as of January 1st of 2022, for most, for individual and employer plans, we have a law called the No Surprises Act. And essentially what that does, I'll spare you the details, but essentially what it does is it says, like, if this was a surprise and you did your due diligence and it turned out this person wasn't in network, then the insurance company has to treat that provider as if they were in network. And there's actually a no surprises help desk through CMS that you can actually reach out to and get help for. I can also send over, we have some tools and information about surprise bills. So that would be my kind of two-step answer. One, is it in network or not? If it is in network and it's a surprise bill, then to file that bill with the no surprises help desk to try to get assistance.
So the last question, and we really value your time, is what is the difference between in-network and preferred provider? I've heard that term quite a bit. That's maybe they'll cover only preferred providers, but someone may be still in network.
Usually they're the same thing.
Okay. That's good. Maybe I'll have to talk to you later because it wasn't the same thing. So that was my question. So I'm glad to know it was more complicated than that.
Yeah, usually they're the same thing. So I would like to know what type of plan that was. There might be a situation where a plan has like, oh, well, I can tell you this. There are some plans that have tiered providers. So
I think that's what it was.
Yeah.
But
okay. So then I can explain that. So in that kind of situation, someone might say, the plan might say, for sake of ease, right? Like these 10 providers are in tier 1. And if you go to a tier 1 provider, we'll cover 90%. But these 30 providers are in tier 2. If you go to one of these providers, we're only going to cover 75%. So they're still in network, but based on the tier that they're in, the insurance company is going to cover them at different rates.
Gotta love how complicated it gets.
I know. That's shame on me for answering too quickly without thinking through all the possibilities, but I think it does speak to how challenging understanding health insurance can be and why we spend so much of our time teaching people about it.
Well, thank you so much for your time. It was absolutely wonderful. And for anybody who's interested in other resources, the Triage Cancer website has a plethora of them.
I really appreciate the invitation. I will just say I got a direct message here if you want me to answer it, but it's a
perfect. Yeah.
question around if someone has Medicare coverage, can they supplement it with a marketplace plan? And the answer is no. If someone has Medicare, you are not eligible to purchase a marketplace plan, but there are plans you can purchase to help supplement that coverage. And if you are on Medicare and have these questions, I really strongly encourage and invite you to come to our Medicare webinar that we're having later this year, where we do a deep dive into all the different parts of Medicare and how to make choices between those different parts.
Well, thank you, everyone. Thank you for spending your evening. And thank you as well, Monica. And I will let everybody go for their evening.
Thank you.